My name is Dr. Claudine Isaacs. I am a breast medical oncologist, and I lead the clinical breast cancer program at Georgetown University at the Lombardi Comprehensive Cancer Center. So the I-SPY2 study is a platform trial. It is a randomized phase 2 neoadjuvant platform trial that is testing multiple different investigational arms versus a shared control. The shared control for a long time had been paclitaxel at 80 milligrams per meter squared weekly for 12 weeks, followed by AC. And then the investigational arms are typically added during the paclitaxel phase. The shared control has actually evolved, but at the time of this arm that we're discussing, the shared control was paclitaxel 80 milligrams per meter squared weekly, and this was without immunotherapy. The rationale for using Cemiplimab plus fianlimib is really building on what we know about the role of immunotherapy in triple negative disease in the neoadjuvant state, and also some of the data that we have suggesting a role for this drug in some women with high-risk hormone receptor positive HER2 negative disease. So I think we all know from the data from the KEYNOTE-522 trial that pembrolizumab has demonstrated an increased pass CR rate and, most importantly, an event-free survival benefit when added on top of standard neoadjuvant chemotherapy. And the rationale for proceeding with pembrolizumab was actually based on the one of the I-SPY2 earlier arms that showed near tripling of pathologic complete response rate in triple negative disease and in high risk hormone receptor positive breast cancer. So we built on that, and in this particular arm, we looked at Cemiplimab, which is a anti-PD-1 antibody that's FDA approved for a number of different malignancies. And we looked at the role of adding fianlimib, which targets another checkpoint inhibitor. Fianlimib is a fully humanized, high-affinity monoclonal antibody that binds to and antagonizes lymphocyte activation gene LAG3. LAG3 is a molecule that's typically expressed on immune cells, including T cells. And we have data that it functions by binding to MHC class 2, which leads to the inhibition of T cell proliferation activation. This drug is also often co-expressed with PD-1, so there's a strong rationale for combining dual checkpoint inhibitor therapy. And in fact, this combination has been looked at in advanced melanoma, untreated advanced melanoma, and recently been shown to be associated with a very high response rate, and then in a recent randomized phase 2/3 trial with this combination, actually prolonged event-free or disease-free survival, compared to the anti-PD-1 alone. This I-SPY2 substudy was focused on the HER2 negative group. So that included triple negative and included high-risk hormone receptor positive HER2 negative patients. In I-SPY, in order to be eligible, if one has a hormone receptor positive disease, one needs to have a high mammoprint. So it's really focusing on the high-risk hormone receptor positive HER2 negative. Additionally, women must have a tumor that's at least 2.5 centimeters. So those are the main eligibility criteria. And this combination, this dual checkpoint inhibitor, was looked at in the triple negative, in the all HER2 negative, in the triple negative subset, as well as in the high risk, the mammoprint high risk hormone receptor positive HER2 negative. And the trial was designed to actually assess whether this combination worked in all three of these subsets. In terms of efficacy, we found that this combination was very active and was active in all three of the subtypes. So the whole group of the HER2 negative, the triple negative, and that high risk hormone receptor positive HER2 negative. And the way that we assessed that was by looking at the PCR rate, or the estimated PCR rate. And for all HER2 negatives, it went from 21% with the paclitaxel alone to 44%. If you looked at the triple negative, it went up to 53%. And the hormone receptor positive HER2 negative, it went to 36%. The other thing that we have done in I-SPY is we've looking at both not only the estimated PCR rate, but looking at a couple of other things. We know that RCB status, or residual cancer burden, is a really important predictor of outcome when we're looking at the benefit of neoadjuvant therapies. So, and we know that RCB0, which is the equivalent of pathologic complete response, and RCB1 together have a very good prognosis, particularly when compared to RCB2 or RCB3. So we've started to look at the shift in the RCB to 0-1 versus 2-3. And we found that in the that this agent or this combination results in a significant shift compared to control arm. And that was true for the HER2 negative overall, for the triple negative, where the RCB0-1 went from 70%, went to 70% with this dual checkpoint inhibition compared to 48% control in the triple negative. And then if you looked at actually that high-risk hormone receptor positive, that's where we showed a really significant difference, where it more than doubled, going from 29%, which is the paclitaxel, to 60%. And that was a really significant shift for us. And then the other thing that we saw in terms of efficacy, trying to drill down on that, is recently we have in the I-SPY group, we've developed biomarker signatures that go beyond just the conventional hormone receptor positive, triple negative, HER2 positive, trying to look at signatures of response. And we've developed this immune signature based on one of our prior arms in I-SPY, based on the pembro alone arm, and then validated in one of our other arms in I-SPY, the durvalumab arm. And in partnership with Agendia, we've developed a diagnostic test known as the imprint test to predict response to immuno-oncology drugs. So we've got this immune positive signature, and those are the women that we think are likeliest to benefit from immunotherapy. So when we looked at how this signature performed within this arm, what we found was that it had a very significant benefit. And if we culled out the immune positive within the triple negative, and again, the numbers are small in this, so we need to be cautious, but we're trying to get at, the whole concept of I-SPY is to try and treat the patient with the drugs that they need and avoid the ones that aren't going to benefit them. And so if we looked at the immune positive signature within the triple negative group, in that group of patients, the ones who got the fianlimib plus Cemiplimab, their estimated PCR rate was 82% compared to 35% with the paclitaxel alone. Then if we looked at the hormone receptor positive HER2 negative, the estimated PCR rate was 91%. I mean, this was a small subset. It was only 11 patients, but 10 of the 11 patients achieved a pass CR rate with this combination. If you looked at the paclitaxel alone arm in this immune positive group, it was only 33%. So nearly a tripling in the pass CR rate, estimated again, pass CR rate, again in small numbers, but certainly tantalizing findings. Now, the issue was that this combination came with toxicity, unfortunately. Not much in terms of non-immune related events, but the thing that we saw was that there was a high rate of adrenal insufficiency, and the adrenal insufficiency rate was 16 patients, or 21% of the patients. And that's obviously a very high rate. And then we also saw some late cases of type 1 diabetes developing in 3 patients. That corresponds to about 4 to 5% of the whole population. But nonetheless, this is obviously, both of these are obviously consequential side effects. And so that's certainly something that we're quite, concerned about in this patient population with curable disease. So one of the things that we're looking at to the future is to look at whether lower doses of the fianlimib might work in this combination, whether we could mitigate some of the toxicities that we saw. So what we're really trying to do is to, define which patients are likeliest to benefit. And while the numbers are small, as I mentioned previously, it's really in this immune positive subset that we saw the most benefit. That being said, I do want to say that there was some benefit in the immune negative group. So interestingly, particularly in the hormone receptor positive, the estimated pass CR rate increased by 20% in the women with immune negative signature who got this combination. Again, tantalizingly, making us wonder whether this dual checkpoint inhibitor therapy might, while the numbers weren't great, maybe it's turning some cold tumors hot. So maybe there's some benefit there. So we really want to investigate all of this, but it really looks like certainly overall, if we look at our study population, it is in triple negative overall, and it is in that high risk hormone receptor positive triple negative. But then if we look at that immune signature, that really seemed to create the greatest difference in terms of benefit of this combination. And again, these numbers are small, and the intent of I-SPY is not to prove something definitively, but to give a signal that it's worth to move this forward to a randomized phase 3 trial with PCR as the primary endpoint, and to help us define some drugs that don't work, and maybe there are only some subtypes. We also want to be thoughtful in how we develop drugs. We don't want to look at a large group and say, oh, it doesn't work and not be able to cull out that small group. So that's why we try and look at it in different signatures so that we give drugs a chance. But also say if something doesn't work, it really doesn't work. It's a great idea, but it doesn't work. So it's not trying to be definitive at all, but trying to give some clear signals that this is something worth moving forward on.